ಅವ್ರಿಗೆ ಗೊತ್ತಾಗತ್ತಕ್ಕೆ ಡೋರ್ ಕ್ಲೋಸ್ ಮಾಡಿ. ಇದು ರೆಕಾರ್ಡಿಂಗ್ ಮಾಡ್ತಾ ಇದ್ದೀರಲ್ಲ. Good morning, all of you. Like today's topic will be fluid and electrolyte imbalance and also the therapy. Let's go over it and see what is there in this. The salt is basically a sodium in the fluid and electrolyte imbalance. The things that we are going to keep in mind is salt, sugar, water, and also the vinegar. Let's see what is there in each one of them. So why a child is more vulnerable to dehydration than the adult? Basically, in the children, there will be an increased body surface area relative to the body weight. And there's a large daily turnover of a fluid which is mainly happens more in the children when compared to the adult. If you see that half of the exchanges, half of the ECF fluid will be, half of the body fluid will be there in the compartment of extracellular fluid in the children, whereas in the case of adults, it is only 1/7, that which mainly constitute about 15%. So you will be knowing at what is this ECF and also the ICF and all those things in the later slides. Okay. So, and also there is a reduced renal concentrating ability will be there. So, in the case of children, the maximum urine osmolality is about 600 milliosmoles in case of children, whereas in the case of adults, it is about 1200 milliosmoles. And normally, when if you are the adult, they express they need water and all those things, whereas the children will, in the case of infancy, they cannot express even the thirst effectively. And the small children, they'll sit in one place and they have a poor access to the water also. So in the previous slide, we already said like about the ECF component, whereas in the, if you see that in the adult, it is about 200 ml. Among that, in the extracellular compartment, about 14 liters will be present. So that is about 15%. And again, they will be excreting about 2000 ml. Whereas in the case of children, the daily turnover is about ECF is about 50%. So here the input is about 700 ml and also the output, but in the case of extracellular compartment, it is around 50%. What is the basis of this salt and water? So to maintain the hemostasis and also in the case of steady state, these are the important components we have to keep in mind. That is temperature, perfusion, and electrolyte balance, that is what we are going to discuss, and hydrogen ion, and the glucose concentration, osmolarity, and later in the slides I'm going to describe what is osmolarity and also the osmolality, oxygenation, and also the hydration. If they are in the balance, then only the hemostasis will be maintained. The hemostasis of fluid electrolyte, there will be in the body, there is a total body water is there. In that, there will be a distribution in extracellular, this total body water will be distributed in extracellular fluid and also the intracellular fluid. In the extracellular fluid, there will be a plasma volume will be there and interstitial fluid will be there. And later on, the third component will be osmolality, and also all these things will be maintained by appropriate electrolyte balance. So which is mainly maintained by sodium, potassium, chloride, and also bicarbonate. So if you see this picture, you can see that 2/3 of the earth is mainly contains the water. In the similar way, the body is also made up of water. So in this, they are given the various distribution of water in the different components of the body, like blood, muscle, kidney, bone, and also in the case of brain. So this is the most important slide. Here we are going to tell about how there is a distribution of the body water component in the various ages. So we already described there is a total body water is there, intracellular fluid is there, and also extracellular fluid. In the case of preterm babies, there will be an extracellular fluid which is and intracellular fluid is almost absent in the case of preterm babies, whereas in the case of term babies and also in the term newborn, the total body water which is mainly constitute about 70%, in that out of 70%, 30% will be extracellular fluid and 40% will be intracellular fluid. Whereas in case of infancy, in the case of and also in the children, the total body water will be 65%. In that, intracellular fluid will be 40% and extracellular fluid will be 25%. In the case of adults, the intracellular fluid will be both male and female, it is about 40%. Whereas in the extracellular fluid, it is about 20% in the case of male and 15% in the case of female. And total body component will be more in the case of male, it is around 60%, and also in the case of female, it is around 55%. So if you see the component of water, which will be the highest component total body water will be present in the case of preterm babies and also in the lowest in the case of females. So it is again the diagram which is mainly showing the extracellular fluid and also the intracellular fluid. In the extracellular fluid, there is an interstitial fluid, intravascular fluid, and also the transcellular fluid. So here it is a subdivision which is going to tell you how the extracellular fluid has been divided. So we have this intravascular fluid, and in that the plasma, where is the 1/4 of it, means 5% of the total body water in the intravascular fluid, whereas in the case of interstitial fluid, which mainly surrounds the cell but does not circulate, which is about 3/4 of the extracellular fluid, which constitute about 15%. Okay, and followed by transcellular fluid, which is mainly the set of fluids. These are outside the normal compartments such as cerebral spinal fluid, that is CSF, pleural, peritoneal, intraocular, digestive juices, mucus, etc. This is about constitute about 1.5%. So if you see this picture, about 5% of the total body water will be in the intravascular fluid, 15% will be in the interstitial fluid, and 1.5% will be in the transcellular fluid. What is this in loss? Well, the water loss, where all it happens? It can happen in insensible water loss and also the sensible water loss. In the case of insensible water loss, there will be lungs which constitute about 15 ml per kg. Whereas in the case of skin, it is about 30 ml per kg. The sensible water loss, what we can notice it, that is the most important one, which happens through the urine. That is around approximately 50 ml per kg. It is about 40 to 70 ml per kg. Whereas in the case of stool, it is about 5 ml per kg. In the case of sweat, it can be as low as 0 up to 20 ml per kg. So insensible water loss, how are we going to calculate? So in the insensible water loss is about 400 ml per meter square of body surface area. That is, which constitute about 1/3 of the maintenance. In case of the insensible water loss will be maximum in the case of infancy, that is around 30 ml per kg, followed by 20 ml per kg in the case of children and 10 ml per kg in the case of adults. So there is different kinds of fluid. We have got cation and also the anion, and there is also a distribution of these ions in the case of extracellular fluid and also the intracellular fluid. The important cat ions are sodium and also the potassium, and sodium is about most important, which is around 140, and also potassium is around 4. Whereas in the case of extracellular fluid, it is mainly the chloride and also the bicarbonate. Coming to the water balance, which is mainly the intake, which is mainly regulated by the thirst, and it is mainly decided by the osmolality and also the volume of plasma. When there is a loss, there is a physiological control is on the volume and also the content of urine. Whenever there is a ADH decreases, there is an antinutric peptide increases the urine volume, where the ADH is released and the plasma osmolality and the plasma volume also changes. Coming to the important electrolyte imbalances, first one we will be discussing is about sodium balance. The dietary intake, what we take normally, that is through the adding the salt to the cooking and all those things, those are the dietary intake. And usually the water balance, which mainly determines the sodium concentration, not the normal sodium balance. The excretion of sodium is mainly in the urine, and it is mainly decided by plasma volume, and it is mainly mediated through renin-angiotensin-aldosterone system. As I already told, there are the few terminologies we need to know about to understand the electrolyte balances, that is osmolarity and also the osmolality. What is this osmolarity? It is mainly the number of osmotically active particles per 1 liter. If you considering it for 1 liter, then it is osmolarity. Whereas in case of osmolality, it is mainly the number of osmotically active particles in 1 kg. If it is with respect to 1 kg, we are always discussing about per kg. If you see in the case of next to the numbers, then they are discussing about osmolality. Tonicity, if you see, means it mainly refers to osmolality of a solution relative to plasma. High osmolality, which is always stimulates the thirst and also the ADH release. For all our clinical purposes, when we are discussing, which is always osmolarity and osmolality, both looks the same. Normally, it is around 285 to 295 milliosmoles, okay, per liter or per kg. What is the formula which is there to calculate our serum osmolality? It is 2 into sodium in millimoles and glucose in milligrams divided by 18 plus urea in milligram divided by 60. Here we have given an example how we should calculate. For example, when we have done the ABG or we have done the electrolytes, if the serum sodium is 140, glucose is 90, urea is 24, then our calculated osmolality by substituting these values, which is around 289, which is normal. So what is this water and sodium? They always has to go hand in hand. That is perfect pair. So the ECF tonicity, which is mainly regulated by the water, whereas the ECF volume, which is mainly regulated by the sodium intake and also the excretion. These are mainly taken care by endocrine, neural, behavioral and also by paracrine systems. Where are the water loss? We already said insensible and also the sensible water loss. The insensible water loss we said through the lungs. So which are the conditions when the patient is ventilated or when the baby is having tachypnea, as in case of bronchiolitis or bronchopneumonia, like that. In the case of skin, it is mainly the burns happen to the skin and also the excessive sweating in the case of cystic fibrosis. In the case of newborn period, when the baby is kept directly under the warmer, so all these conditions, there will be a loss of water. In the case of urine, if the child is suffering from diabetes mellitus, diabetes insipidus, and if they are in diuretics for any there's an hypertension or anything like that, or if they have taken the mannitol for increased intracranial pressure, it can loss of water can also happen in the case of GI loss, as in the case of diarrhea or vomiting. So we already mentioned the normal plasma osmolality is around 280 to 295 milliosmoles per liter. There is we already told this is one of the important antidiuretic hormone. Even there is a change of 1 milliosmoles will lead to significant changes in ADH secretion. Increase in osmolality will decrease the ADH secretion. So thirst, there is an increase in osmolality will increase the thirst. How do we define the tonicity? It is mainly, there are the osmoreceptors, which is mainly present in the hypothalamus, which mainly senses the plasma osmolality. And it is mainly balanced by intake and also the excretion. The intake is mainly through the thirst and excretion is mainly regulated through antidiuretic hormone. We already know the serum osmolality, which is mainly the principal determinant, the principal electrolyte which is involved is mainly the sodium. The minimum urine osmolality will be around 30 to 50 milliosmoles per liter. This places an upper limit for the kidney for the water excretion, hence the water intoxication can also cause severe hypernatremia. Regarding the volume, that is plasma osmolality, which is mainly the amount of sodium plasma, which is the main determinant of osmolality, so the ECF volume also. The water excretion, which is mainly maintained through antidiuretic hormone, angiotensin 2, and also the antinatriuretic peptide. So how we can define the volume? If the ECF extracellular fluid volume falls by osmotic fluid stimuli, by the osmotic stimuli, thirst and also the ADH both will increase the ECF volume. By volume stimuli, the ADH is secreted and the water retention and increase in ECF volume. And in the case of angiotensin 2 increases the thirst, increase ADH secretion and the sodium absorption in the distal convoluted tubule and also in the case of collecting duct. Whereas when the ADH secretion decreases and hence the water excretion will leads to fall in extracellular fluid volume. And anti-natriuretic peptide is secreted and it mainly leads to natriuresis. Coming to the ADH, which is not at all, or the ADH is not an all or none phenomena. It is graded and also one guided by mainly osmolarity. Under the condition of hyperosmolarity, ADH secretion is initiated prior to the onset of thirst, allowing for retention of mainly the ingested water. And the next one will be the aldosterone, which mainly responds to fall in ineffective circulation volume. It acts mainly by renin-angiotensin aldosterone axis and it mainly enhances the renal tubular reabsorption of sodium. Atrial natriuretic peptide, which is play an important role in regulating the blood volume and also the pressure. It mainly responds to excessive circulating volume and it mainly acts by causing a natriuresis and also the diuresis, and it mainly inhibits angiotensin 2 induced vasoconstriction and it also inhibits the release of antidiuretic hormone. So it is mainly, this is the another important chart and it will tell us what is the electrolyte imbalance that happens whenever there is a diarrhea. There is mainly a loss of sodium and also the equal loss of sodium and also the potassium. Whereas in the case of gastritis, basically there is a vomiting, there is a more loss of sodium than the potassium. Whereas in the case of small intestine, there is a more loss of sodium in the water rather than the potassium. Even in the case of ileostomy, it is more loss of sodium rather than the potassium. And there is in all the cases there is a loss of sodium bicarbonate also, whereas in the case of vomiting there is no loss of bicarbonate. So how are we going to calculate the IV maintenance fluid? There are the different formulas. That is, first one is the Holiday-Segar formula. That is per day. You can calculate per day basis also, or in the case of hourly basis also. In the case of per day, it is mainly up to 10 kg body weight. It is 100 ml per kg. That is, for the 1 kg it is 100 ml. For 10 kgs it is up to 1000 ml. In case of 11 to 20 kg, it is 1000 plus 50 ml per kg for every 1 kg rise of more than 10. If it is 12 kg means 1000 plus 50, that is 1100. In the case of more than 21 kg, it is 1500 plus 20. Means if it is baby is 22 kgs means it is 50 plus 50, 100. So it is 1500 plus 100, that is 1600. That is if you are calculating per day basis. If you are calculating per hourly basis, so up to 10 kgs of body weight, it is 4 ml per kg per hour. Whereas in case of 11 to 20 kgs, it is 40 ml plus 2 ml per kg per hour for 1 kg for every 1 kg of more than 10 kgs. If it is more than 21 kg, it is 1500 plus 20 ml per kg for every more than 1 kg more than 20 kgs. So there is a requirement changes depending upon the type of condition. For example, if the child is having fever, there is a 12% increase in the maintenance of fluid per degree. If it is 99 to 100, it is going, there is a 12% increase degree. In case of hyperventilation, it is 10 to 60 ml per kg per 100 kilocalories. In case of sweating, it is 100 to 60 ml per kg. In case of humidified ventilation, the maintenance will be reduced. In case of GI and renal loss, we need to calculate how much percent of dehydration has happened. According to that, we have to adjust the IV maintenance fluid. So what are the different type of solutions which is mainly available with respect to age? If the child is less than 10 kgs of body weight, then we have 5% dextrose with 1/4 normal saline plus 20 millimoles of a liter of potassium chloride. Whereas in case of older children like 11 kgs of more of weight, that is approximately like 2-year child, 1.5 to 2-year old child, then it is 5% dextrose with half normal saline with the same amount of potassium. When should we give this isotonic fluid? Isotonic fluids are mainly the normal saline and also the ringer lactate. They are indicated in a child with any kind of shock, basically hypovolemic shock. Hypotonic fluids such as half normal saline, that is 1/2 normal saline, isolate P, and dextrose containing solutions such as dextrose solution which are not given as a bolus in presence of shock. Hypotonic fluids are not given in shock. It is mainly the isotonic fluid which is normal saline and ringer lactate are mainly indicated. What happens in the case of CNS disorders? It is mainly the isotonic saline, which is normal saline alone, along with appropriate dextrose and also the potassium. So in this case, we have to maintain the serum sodium around 145 to 150, and we have to maintain the normal volume by giving either the isotonic saline, that is normal saline, unless the child is having SIADH, and also the frequent monitoring of sodium is important. What are the different type of IV fluids which is available over the counter? Which is D5 means 5% dextrose, D10 is 10% dextrose, NS is normal saline, RL is mainly the ringer lactate, DNS is it contains 5% of dextrose along with the normal saline. Half DNS means it contains same 5% of dextrose along with half of the normal saline. Isolate P and 3% NS means it is mainly a hypertonic solution. So we came to know that what are the IV fluids which is available. So it is also important to know what amount of milliequivalents amount of electrolyte which is mainly present in each one of them. In the normal saline, it contains an equal amount of 0.9 normal saline if you say, or if you just say normal saline, it mainly contains 154 sodium and also the 154 equal amount of sodium and chloride. In the dextrose saline means again it is the same thing, which is 5% dextrose it contains with the equal amount of 154 milliequivalent of sodium and also the chloride. Whereas off a saline means 77 and 77 of sodium and chloride each. In the case of RL, along with the sodium and chloride, it also contains potassium and also the bicarbonate. In 5% dextrose, it doesn't contain, only if you say 5% dextrose means it doesn't contain any of the electrolytes, it contains only the sugar. As we already said, isolate P, it is a hypotonic solution which mainly contains only the 30 of sodium and also the 20 milliequivalent of potassium. So what are the things we have to keep in mind for the clinical evaluation? First of all, we need to know, is there any signs of dehydration? If so, the type and the degree of dehydration, any electrolyte disturbances if the child is suffering, any acid-base disturbances, and how is the renal function in the case of child. So there are the different type of dehydration. The one is the mild, which is mainly constitute about 5% in the case of infants and 3% in children. In case of moderate dehydration, it is 10%, whereas in the case of children, it is 15%. In the case of child, it is 6% and also the 9%. Okay. Coming to the what happened, we have calculated depending upon the degree of dehydration. Depending upon the type of tonicity, if the hypotonic means the osmolality will be less than 270 with the sodium of less than 130, and isotonic is 270 to 300. This is around sodium will be 130 to 150. Hypertonic will be more than 300, and this one sodium will be more than 150. There are the conditions which will also lead to overhydration, where there's an accumulation of fluid. If it is in the intravascular fluid, then the conditions will be hypertension, respiratory distress, and pulmonary edema. In the case of interstitial space, there will be an accumulation of fluid, then it is called edema, which is mainly present in the periorbital region, and also in the case of puffiness around the eyes, and also in the sacral region. And there is a transcellular fluid we already discussed, which is in the transcellular fluid, which is mainly in the ascites and also the pleural fluid. Depending upon the degree of dehydration, which can refer to the ECF volume, which can say as a mild, moderate, and severe. And plasma sodium is the one which mainly decides the type of dehydration. As we already discussed this one, that is isotonic, hypotonic, and also the hypertonic. So the concentration of this one, what is that IV? What is the amount, how much milli equivalents it is in if it is 1 ml IV preparation? If it is of the sodium, if it is 3% NS means it mainly contains 0.5 milli equivalent of this one, what is that, sodium. Whereas in the case of NS it is 0.15, okay. And if it is 8.4% sodium bicarbonate means it contains 1 milliequivalent of sodium and also the bicarbonate. Whereas potassium chloride, it mainly contains 2 milliequivalent of this one potassium. The important thing here we have to see is, though both are calcium, one is calcium gluconate, the other one is calcium chloride. In 10% of calcium gluconate, it is mainly the 9.3 milligram of elemental calcium. In the same with the 10% chloride, calcium chloride, it is 27.3 mg of elemental calcium. So, when should we start with the electrolyte treatment? In the presence of dehydration, or if the child is having shock, any child coming with a convulsions or neurological disturbance like weakness, any child not gaining a weight or a fast breathing with respect to normal respiratory examination, or in presence of features which is suggestive of renal failure. This is the time we have to order for electrolyte estimation. So we have got hyponatremia. In that we have got true hyponatremia and also the pseudo hyponatremia. In the true hyponatremia, we have got hypovolemic, isovolemic, and also the hypervolemic. What do you mean by pseudo hyponatremia? This one, hypernatremia, which is usually associated with low serum osmolality. It can be a normal or the eye. We have to suspect about pseudo. That is improper sampling of the vein or to the IV proximal site. Pseudo hyponatremia, where there is a normal osmolality, and here the patient is suffering from hyperlipidemia or hyperproteinemia, or fictitious hypernatremia, where there is a high milliosmoles with respect to hyperglycemia in the case of diabetes mellitus and also in the case of mannitol infusion. What are the different, we have already said, hypovolemic hyponatremia, euvolemic hypernatremia, hypervolemic hypernatremia. Hypo means here both the sodium and water deficit is there. Euvolemic will be water excess. Hypervolemic means water and also the sodium excess. The important causes will be extrarenal losses. In the case of hypovolemic, extrarenal causes, which is vomiting, diarrhea, third spacing. Whereas in the case of renal losses, which is mainly the urine sodium will be less than 20. In case of RTA, renal tubular acidosis, cerebral salt wasting, osmotic diuresis, diabetic ketoacidosis, diuretic therapy, adrenal insufficiency, pseudo hypoaldosteronism. In the case of hypovolemic or hypovolemic hyponatremia, where there is a water intoxication, which mainly uses 5% dextrose in post-operative period, psychogenic water drinking, and tap water enema, or in the case of SIADH. Hypervolemic is where there is a renal failure and urinary sodium is more than 40 millimole per liter, and all the others will have urinary sodium of less than 20 milliequivalent. There is a nephrotic syndrome, congestive heart failure, protein energy malnutrition, and also the cirrhosis of the liver. Let's see, like there is a case scenario where the child is having acute GE with convulsion. The patient is coming to the ER, dehydrated, irritable, weak peripheral pulses, where the heart rate is 180, blood pressure is around 80 to 50, and the child has not passed the urine since last 8 hours, SpO2 of 93% with oxygen, maintaining 93% with O2. Here the serums, done the ABG and also the electrolytes has been sent. The reports are as follows. Here the serum sodium is 162, potassium of 3.5, bicarbonate of 20, urea 50, creatinine 1. Here the child is having a diarrheal disease with a shock and also the hypernatremic dehydration. Coming to the hypernatremia causes, the year where the dehydration, where they have the diarrhea and also the diabetes insipidus with normal hydration or edema, then it is sodium excess, then will be the ORS, bicarbonate therapy and hypertonic saline, hyperaldosteronism and also the Cushing syndrome. So this is basically a pictorial where, for example, if you put the hypernatremic means if you put it in the pickle, they'll before making the pickle, they'll put the mangoes or lemon in the case, put it in the lot of soil, which mainly shows it is shrunken. Here, even in the case of hypernatremic dehydration also, there will be a shrunken skin will be present. Coming to the hypokalemia, the causes there will be divided into renal loss and GI loss. In the case of renal loss, it is renal tubular acidosis, diuretic therapy, and also the Bartter syndrome. In the case of GI losses, there will be a vomiting, diarrhea, laxity abuse, where there is a shift of potassium from extracellular fluid to the intracellular fluid, alkalosis, and insulin treatment in the case of diabetic ketoacidosis, beta 2 agonist, mainly the nebulization, which is mainly given the treatment of asthma, limited intake, as in the case of children with malnutrition, receiving potassium for free IV fluid. How do the patient presents if they have hypokalemia? There will be a muscle weakness, headache, head lag, hypotonia, weakness of limbs, phantom hernia, paralytic ileus. And they have the arrhythmia, which is particularly when the child is on digitalis, and there's a features of primary disease, and there will be ECG changes, which showing a depressed T waves, appearance of U wave, and also the ST segment depression. The causes for hyperkalemia. There is a defective excretion which mainly happens if there is a renal failure, hypoaldosteronism, hyporeninic hypoaldosteronism. Drugs will be the spironolactone, ACE inhibitor, shift from ICF to intracellular fluid, acute intravascular hemolysis, trauma, tumor lysis syndrome, and also the acidosis and adrenal insufficiency. What are the ECG changes we are going to see? That is hyperkalemia, which is mainly the peak in the T waves, prolonged PR interval, ST segment depression, wide QRS complex. Hypokalemia, there is a flat inverted T wave and there is an appearance of U wave and ST segment depression. What are the things we have to monitor when they come with the dehydration? We have to first thing is history, which is mainly you have to ask for any vomiting, diarrhea, urine output loss, any other losses, and also the altered sensorium. In the examination, we have to do if there's an edema, which is mainly the pedal, sacral-apedal edema, hepatomegaly, and neck veins in the case of older children. You have to monitor the heart rate, BP, and also if there's a fluid overload or there's a decreased amount of air entry in the lung fields or anything like that. In the bedside, we have to check for about body weight, input output chart, and also the urine color and also the specific gravity. Okay. And electrolyte, that is what are the investigations we have to send for the electrolytes, blood urea, serum creatinine, hematocrit, serum osmolality, and also the urine specific gravity. So this is basically a critical care, which is mainly showing the place of the this one, how the dehydration status and ventilated chain, how we have to monitor and all those things. So before going into the last slide, like there are the few other things I would like to discuss. The one is mainly the this one. What is that? Another electrolytes, which is mainly the magnesium. So basically the hypomagnesemia. So hypomagnesemia, which is mainly seen in the case of hospitalized patients, and most of the cases they will be asymptomatic. So we have to have an high index of suspicion because the magnesium cannot be measured in most of the normally they don't check whenever we send for the electrolyte this one testing. Normally they don't check the magnesium unless otherwise we specify that. So we should have to be have a high index of suspicion, and also we have to send for the sample only if you have a high index of suspicion. So what are the conditions which mainly causes hypomagnesemia? Already we know that these are gastrointestinal disorders, which is mainly diarrhea, nasogastric this one suction, or the emesis, and inflammatory bowel diseases, that is Crohn's, and also the ulcerative colitis, celiac disease, cystic fibrosis, pancreatitis, protein energy malnutrition, all those things will cause hypomagnesemia. So when do they have the features of hypomagnesemia? So basically whenever the magnesium levels is less than 0.7 milligram per deciliter. What is the most important manifestations if they have hypomagnesemia? Which is mainly they manifest similar to the hypocalcemia. So basically tetany will be present, and there is a presence of Trouser's sign and also the seizures. Whenever they have a severe hypomagnesemia, they have almost same signs and symptoms, which is mainly features of this one. What is that? Hypocalcemia, despite of they have normal calcium. Here, when you check your this one, what is that investigation? The child will have the normal calcium signs, normal calcium levels, but they will have the features which is mainly in the case of tetany will be present, seizures will be present. So even that persistent hypocalcemia can also lead to hypomagnesemia, and some of the rickets can cause this. Therefore we have to keep in mind always whenever they have the hypo normal calcemia is there, but there are the features which is mainly suggestive of seizures and tetany will be present, then we have to rule out about hypomagnesemia. So what are the ECG changes? The ECG changes will be the flattening of T waves and also the lengthening of ST segment, and arrhythmia can also present if they have underlying this one, what is that, heart disease. The other thing is how we should manage this hypomagnesemia. So the magnesium sulfate is usually will be given in the dose of 25 to 50 mg per kg. It is available in the solution form, and it has to be administered slow IV infusion, and it can be given intramuscularly in the case of neonates. And the dose can be repeated once in 6 hours, and we can give up to total of 2 to 3 doses. So before that we have always important to check the plasma magnesium level. And the other thing is once we have done the correction, it is important to check again that whether after giving the 3 doses whether the magnesium level has come to has returned to the normal level or not. The one I told about hypomagnesemia. The another thing is hypermagnesemia. So hypermagnesemia is almost always secondary to excessive intake. So it is the most important thing is mainly it happens during the delivery, if the mother is suffering from the eclampsia, then there will be a to control the eclampsia, the magnesium sulfate will be given to the mother. So this magnesium sulfate will be transferred to the newborn. So it is important to know that the history of the whether the mother has received any magnesium sulfate to control the eclampsia. So the most important thing is whenever there's a magnesium level of plasma, whenever we check the plasma magnesium level of more than more than 4.5, it is always suggestive of this one. What is that? Hypermagnesemia. So how are we going to treat this one? So it is mainly it is mainly because of taking orally or transplacentally transfer of the magnesium. So it has to be cleared out. It is mainly through intravenous hydration or the loop diuretics, and it is mainly through the hemodialysis, or the dialysis is mainly most important in the case of hypomagnesemia. So the most important thing we have to keep in the mind is, so in the exam point of view, we need to know what is hyponatremia and also the hypernatremia, hypocalcemia, hypercalcemia, and also the hypomagnesemia and hypermagnesemia. And there are the, you may get individually hyponatremia, hypernatremia, which will not be present. The child can have the case of, the child can present in the case of severe dehydration or some dehydration, moderate dehydration. These are the conditions which will tell about the hyponatremia or the hypokalemia, and along with that potassium imbalance will also be present. Attendance.